engage in the chat. I'm going to hand over to Dr. Lamaya because we're desperate to finish on time. So Rupali Lamaya is an associate scientist in the Department of International Health at Johns Hopkins School of Public Health. She's an expert in improving vaccine confidence and has several NIH funded grants for this very topic. So Dr. Lamaya, I'm going to invite you to share your screen and please take it away. Thank you so much for joining us today. Dr. Lamaya, are you able to join us? Dr. Lamaya is muted. Japaigo, please could you unmute her?
Hi, everyone. I think it's finally working. Sorry, I was unable to unmute myself. If I could gain permission to share my screen, that would be wonderful.
Japaigo, are you able to do that, please?
I think it is now working. It just came through. Okay.
Perfect. Thank you.
Great. Hopefully everyone can see my screen. I'm going to move us along, and thank you for having me here today. As Dr. Hansoti mentioned, my name is Rupali Lamay. I'm in the Department of International Health, as well as Epidemiology and Health Behavior and Society at the Johns Hopkins Bloomberg School of Public Health. I'm going to focus on three very quick things today. I'm going to talk about some of the common COVID-19 vaccine myths that we have been seeing globally. I'm going to talk very briefly about what are some of the drivers as to why we're having so much vaccine hesitancy related to COVID. And then I'll spend just a few minutes talking about some tried and true evidence-based communication techniques specifically for vaccine acceptance. So let me start with some myths. We recently did a training with a number of individuals from the American Academy of Pediatrics here in the United States, as well as the ACOG, which is our obstetrics and gynecology organization here in the United States, trying to really think about the ways in which we can equip providers with some of the main myths that we're hearing. And according to the last two presentations, one of the key issues that we've continued to hear, especially from women, is this idea around fertility. The myth that we hear quite a bit is that the COVID-19 vaccine can affect women's fertility. And the way that we've been refuting this is very straightforward. So far, we've looked at the evidence. We have found that there's no effect with regards to the COVID-19 vaccines on fertility. And rather, the counseling should really focusing on actually getting the COVID-19 itself, on the other hand, can have potentially serious impact, not only on the pregnancy itself, but also on the mother's health. And so that's the way we've been sort of focusing on, I think, busting this myth, if you will. The second myth that we hear, and we continue to hear this from a clinical setting as well as in a community-based setting, is that if individuals have already had COVID-19, they don't need a vaccine. I think many of us know here the way that we need to talk about this and counsel this is that we do know that because of severe health risks related to COVID-19 and because we know reinfection does occur, it's really important to continue to promote vaccination among individuals that have already told you they have gotten COVID-19. The reason that we want to continue to promote this is because there's not enough information currently from a data perspective to say how long people that were naturally exposed, i.e. got COVID, how long their immunity lasts. The next myth that we continue to hear is the issue that the development process was rushed. And this is across vaccines. These are just not vaccines that are available here in the United States. This is globally. One of the things that we try to stress when we hear this myth is that we do know that trial participants and individuals that have since then received the vaccine after an EUA has been passed or a full approval has been passed, is that essentially there's three key reasons that we try to explain to individuals. We've been able to leverage a technology that has been in place for a long time in the case of the mRNA vaccines, for example. We also stress that there was no skipping of any steps from a vaccine development and clinical trial perspective, but essentially in an emergency, individuals and organizations from these different companies that are running these clinical trials are able to essentially overlap steps. The third reason as to why we really try to stress is that the reason that the development of the vaccines and we were able to get a vaccine within a year after we had sequenced essentially COVID-19 was simply because there was a lot of money and resources that was put behind this effort. With regards to side effects, this is the #1 reason that we get from individuals as to why they don't want to get the vaccine. The way we try to explain this is that we talk about the vaccine like any other therapeutic product. So for example, if your patient is on blood pressure medication, for example, or cholesterol medication, there are still side effects to that medication as well. What we try to do is stress that the benefits outweigh the risks, and we try to focus on severity related to COVID. Finally, the last myth that we continue to hear is this idea related to the mRNA vaccines, that if you get one of the mRNA vaccines, that it enters your cells and changes your DNA. The way that we have been really trying to bust this myth is really talk about the ways in which the vaccine works. And we have actually found, I think many people might resist this and say, I don't think people understand the vaccine. And you'd be surprised if you can explain this process. People actually do explain how an mRNA vaccine and understand how an mRNA vaccine works. The last piece that I'll talk on briefly is this idea of COVID-19 vaccines and masks. We've seen this particularly here in the United States, but we're also seeing this around in other settings. So getting the vaccine means that I can stop wearing my mask. We continue to try to promote in any setting individuals to continue to wear masks, and that's simply because we know that not enough of the population is yet vaccinated. We do know that COVID-19 is continuing to circulate, and so we also use this opportunity to not only talk about masks, but to talk about other non-pharmaceutical interventions, including social distancing, for example. So, what is driving hesitancy within this context? I just have one quick slide. And one thing that we have seen globally in a number of different settings, the first is distrust and a lack of confidence. So distrust in the vaccine development process, in the healthcare system, for example. The lack of confidence is not only related to the efficacy of the vaccine itself, but also with regards to information that maybe has not been so clear with regards to when people should get the vaccine, when a booster dose may be available, and so forth. Misinformation has been a key issue, and several of us have been studying this to try to determine what are some key strategies we can use to really mitigate this issue. As many of you know, a lot of this misinformation has been fueled by social media. For example, many of us have been working with social media platforms to better understand how we can flag misinformation quickly so that we can make sure it doesn't spread. The last piece we're really seeing is the polarization of attitudes. 20 years ago, from a healthcare provider perspective, if you told a patient to get a vaccine, 99% of those patients would get a vaccine. That has shifted quite a bit. We have much more polarized attitudes. Individuals want to do their quote unquote research, and individuals are much more ego focused, meaning they have stronger opinions and attitudes towards vaccination than they did 20 years ago. So the question is, how should we communicate about vaccines, especially in this sort of fact-resistant world that we are living in? I'm going to touch on just a few key issues. I could go on and on about this, but one thing that I want to focus on that's very important: healthcare providers still remain the most trusted advisor and influencer of health decisions. This has shifted over time. Over the last 20 years, we've seen a decrease in trust towards healthcare providers, but individuals still rely on healthcare providers. So we've developed a step-by-step process on how to do this. So the first is using something called an availability heuristic. And essentially what this does, it describes our propensity to estimate the probability of an event. Let me give you a quick example. So when we think about things that commonly come to mind, it's easy for us to recall things like when a plane crashes, we're less likely to say, oh, you know what, I had a really safe flight. So as a result, because top of mind, you think about a plane crash when you hear about it in the news, this can lead to something called fear of flying. So it's important when we talk about side effects, for example, or safety related to the vaccine, that we try to leverage this idea of the availability heuristic. Another key piece that we have tested is this idea of not correcting misperceptions. I think when a patient comes and a patient says something like, I know there's a microchip in the vaccine, which we've heard a lot, one thing that we have learned through lots of different trials is we should not be correcting misperceptions. Instead, what we should be doing is something called the pivoting effect. And what that means is that instead you automatically shift the conversation and you focus on the disease itself. This is really important for individuals because if you try to correct those that come to you with perhaps rumors or conspiracy theories, that will essentially lead to more distrust and they'll be less likely to take your recommendation. The last piece that I want to talk about very, very briefly that we have outlined is this idea of using nudges and defaults. So something called presumptive communication, or I think someone mentioned earlier, motivational interviewing, for example. Here's an example of how this is done from a pediatric perspective. Essentially, the way that this works is when a child comes in, and if they are due for a vaccine, you automatically assume that the parents will vaccinate their child. So instead of saying, your son is due for a vaccination, would you like me to get it ready? The conversation would go something like this. Your son is due for a vaccine. I have it ready for you. So you automatically make it the default that the child will accept the vaccine and the parent will accept the vaccine. So this has been tested not only in the pediatric sense, but also in the adult sense in a number of different contexts, including the COVID-19 vaccine. A few other key things to think about. Many of us and much of this work has really been driven by thinking about social norms, so understanding what our friends are doing. I think in the panel, there was just a discussion about hesitancy among healthcare providers. If you see the middle panel of this graphic, you can see here it says 3 of 4 healthcare workers got flu vaccines. This idea that your peers are getting the vaccine is very influential as to whether or not you'll get the vaccine itself. So it's important to leverage these social norms among communities where individuals are really looking to an opinion leader to help inform their own decision about a vaccine. Finally, we use something called pre-bunking inoculation, and we're testing this approach in a trial currently. The idea behind this is that if people have beliefs related to conspiracy or misinformation, what we can do is essentially immunize people against these types of arguments. The way that this works is just as a vaccine is an administration of a weakened dose of a virus triggers antibody in an immune system. If you preemptively expose individuals to weakened examples of common techniques related to misinformation, this helps them essentially prepare for when they are confronted with misinformation. An example I can show you here that I would suggest if you're interested in this kind of work is there is a very fascinating game called Bad News, and the individuals that developed this game have developed a secondary game called Go Viral. And essentially what you do in this game is you take the role of an aspiring fake news tycoon, i.e. spreading misinformation. And what you do is you learn the techniques of misinformation. And from there, it's really an anti-misinformation tool by making sure that this works across demographics. And we've been trying to apply this, and we're testing this essentially using this game and applying it to a training to really train frontline workers in 4 different lower income settings. In terms of some of this work, we've actually written a book that has really outlined many of these ideas. I could go on and on and on about many of these approaches, but I wanted to just give you a quick sense of some of the work that we have tried that has been really rooted in the evidence with regards to communication. So thank you so much. Back over to the facilitators. So I'm not sure what the next step is. Sorry, I think we lost Bhakti maybe. Maybe we have a few minutes for questions that we can entertain. Oh, I think it's over to Dr. Prem, sorry.
Yeah, I think we can go for the questions. There was one hand up at that time, Ankita. Oh, Anita Rani.
So there was one question on the gender gap that exists in the.
So regarding the gender gap, it is not much. Like if we see there are total 50.16 crore males have been immunized in comparison to 46 crore females, which is around 4 crore. But seeing the gender ratio, almost 48% of current target of female has been immunized. But definitely in some states there is, and this might be due to because of this pregnant and lactating female we have included in later stages. So still, as we have seen in the case studies, still there are apprehension and some issues related to it. And once it is it is responded well through a medical people, definitely more pregnant female and lactating female will go for the vaccination.
Thank you so much for your response. Apologies that I disappeared for a second. I got kicked off, but I'm back. And Rupali, thank you so much for a really informative and concise presentation. I was able to hear the end of it. The slides will be, hopefully the slides can be made available, or at least we can copy some of those facts and methods, and we'll disseminate that widely. I'm going to suggest that we end unless there's any other questions. Prem, is there any other questions in the chat that I may have missed?
I think chat we have addressed. There is one hand raised, Anita Rani, but...
There was one question, Bhakti, related to recommendation for the booster dose for COVID vaccination. I wonder if we can address that.
Chris, would you be willing to recommend the current thinking around booster doses beyond the United States and the recommendations currently?
Sure. I sit on the WHO SAGE COVID vaccines working group, so I'm really representing that view rather than Indian government. And I think two key points. Booster doses will come for most people, but not yet. And the people who have already received their full primary course, usually 2 vaccinations, can be comfortable that those 2 doses are still protecting well against severe disease and hospitalisation. And that's why the priority is to get more people receiving their primary course. That really, at a population level, has to come before boosters. The recommendation that came out last week from WHO SAGE is that booster doses should be given to people with immune deficiency or compromised immune systems for different reasons, whether because they're on medication, like the woman with rheumatoid arthritis on methylprednisolone that was presented earlier, or because they're living with active, poorly treated HIV infection, or some other cause, other people who are on immunosuppressive treatment for cancer therapies. So there's a range of people who do need an additional dose. WHO are not calling that additional dose for immunocompromised a booster. They're calling it an additional 3rd dose because it is really to make up for the fact that their response to the primary series is less than people who have fully competent immune systems. So at the moment, that additional dose for people with immune compromise is the only global recommendation on boosters, and we need to still get as many people as possible on receiving their primary series. There is worrying, the most worrying data on boosters comes from Israel, and they had a very specific vaccine rollout with a very specific short time period and set of vaccines. So I guess I want to end with that key message that if you've had a full primary series, you're still well protected, even up to 9 months down the track, against severe disease or hospitalization. Thank you.
Thank you, Chris. There is another question, Bhakti, in the chat box about if someone has crossed the specified time for 2nd dose, should he or she should be provided with the 2nd dose or start all over again? I think it's pretty straightforward. Please.
Chris, if I can ask you to address that question, and then I think we should stop, Dr. Sharma, because we are at time.
Yeah, totally agree.
Yeah, I think there's no reason to start again. You just give the later dose at the first possible opportunity.
So lots of good questions, and I think it just shows how much each of us is also confused about this vaccine environment. So no wonder our patients are also struggling. Colleagues from AIMS Bhopal, Dr. Joshi, any last remarks or parting words before we close the session today?
Thank you, Bhakti. So basically, the evidences are emerging, and we are learning as the time is moving, and the disease is a new one. Disease is entirely a new phenomenon, and it has also created some chaos and confusion. But the good thing is we are trying to understand the pattern from this confusion, and we are trying to understand what are the possible interconnectedness or what are the possible interlinkings in this chaos. And as we are seeing, as the time moves, we will be able to say speak with more confidence. So it is the time which will tell us.
Right. And then all of you on this call, if you have any need for additional guidance, documentations, job aids, please reach out to Dr. Prem Singh. We definitely have some of our hub or clinical excellence facilities that are creating materials that can be used to help with our own language and our communication. And I'm sure Dr. Prem Singh will be able to disseminate those informations more broadly. So I'm going to suggest that we end today. Apologies for running a little bit over and for the technical difficulties that were presented. You know, this has been a very interesting case series and we are about to end. So in 2 weeks' time, we're going to speak with our AIMS Delhi colleagues about point of care diagnostics in COVID. And this is, you know, not only have like the rapidity with point of care diagnostics now available has gone through the roof, but also the variety and the types of the different tests. So we want to review the evidence-based strategies on those diagnostic tests and making clinical decisions based on the different tests that are available. I want to sincerely thank our colleagues from AIMS Bhopal for presenting 2 very interesting cases. And really, like, whilst vaccine hesitancy tends to affect all populations, the case of the pregnant mother is particularly challenging due to some of the lack of data and confusion in that population. So it was a very interesting case, and thank you very, very much. With that, I will end. Please remember that we here at RISE are here to work with the hub and spoke facilities. Well, this webinar is just the tip of the iceberg, right? So if you are there and you're asking for services at your facility, workshops, training opportunities, materials that you can disseminate, please reach out to your representatives here that are on the screen, Dr. Nochiketa Mohanty, Dr. Surendra Sharma, and Dr. Jen Daniels. And they would be more than happy to assist you and connect you either to your regional hub facility or to the broader global technical assistance that is available. Have a great day. Please go get vaccinated and encourage all of those around you to do the same.